Hey guys, how's it going? My name is Sahil. I'm one of the sleep docs here at EmpowerSleep. Over the next few minutes, more like 5 to 7, I'm gonna just walk you through what to expect at EmpowerSleep, um, who's on the team, um, what to, what the expectations are, and like really who would just be a really good fit for joining the team here at EmpowerSleep. So let me go ahead and minimize my screen. So you should be able to see my screen now. So on the clinical side, there are currently two physicians, NP, uh, two coaches, and one sleep psychologist who's joining. So we have another sleep coach who's joining, and another sleep psychologist who will be joining by the time whoever eventually ends up starting. My background, I'm pulmonary critical care sleep medicine trained. I did residency in 2010 to 2013 at one of the UCLA programs. Worked as a hospitalist for about 3 years, and I loved working in the unit. Ended up doing pulmonary critical care at Loma Linda. Then became really interested in doing sleep medicine. Ended up doing sleep medicine in Boston at BI. And Harvard has two programs. One is through the Brigham. The other one is through um, BI, and the BI program is across Boston Children's, BI, and MGH, and just a phenomenal program. And for me, I finished fellowship in 2020, and the idea for me was like, how do I sort of reproduce this kind of Harvard grade sleep care and do it for myself? And since then, the program has evolved substantially, and we can talk more about that when we meet. Other folks on the team that are, again, just rock star clinicians, physicians, coaches. One of them is Dr. Stacy Gunn. She's internal medicine, sleep medicine trained. She also trained at the BI. She is like my attending. I'm really grateful that she's on our team. In addition to that, we have Kayla, who's a phenomenal NP, understands the different endotypes and phenotypes of sleep apnea, insomnia, understands RLS. We have Callie, who is a phenomenal sleep coach, helps with all things that are coaching related, from CPAP mask to insomnia coaching. And now we're going to have a dedicated sleep psychologist who's going to unload all of the insomnia patients for formal CBTI, ACT therapy, and so forth. Um, you know, Traditional sleep medicine is uh, it's good, but I'm not a big fan of it. It's single night testing, maybe 2 night testing, very cookie cutter solutions. Sleep apnea tests are Sleep studies are considered sleep apnea tests. Um, if you talk to a radiologist, they would never say that a X-ray is a pneumonia test. A CT angio is not a pulmonary embolism test, and similarly, like I strongly feel that a sleep study is not a sleep apnea test. It's a measurement of physiology when someone's sleeping, and that's our responsibility to figure that out. Figure out what's going on and how we can improve it. I think that's the first fundamental difference here at Empower Sleep is how we look at sleep. The second fundamental difference at Empower Sleep is that we're doing sleep studies longitudinally across time. Like this, like 1 night, 2 night nonsense. Like we don't do any of that. I just give the sensor to the patient. In this picture, you're seeing a sleep image ring, and I say, hey, do a sleep study as many nights as you want to. I want at least 7 to 10 night baseline so I can see what's happening on weekdays, weekends, alcohol, without alcohol, medication, sedatives, supplements, whatever the patient wants to tell me, so I can get a better sense of like what is this person's sleep health like across this like 7 to 10 day window, from a timing, duration, quality, apnea, heart rate dipping, movement, all of that standpoint before I come up with any kind of a plan. And we've built software that lets the patient see their results every morning in the app. This is just a picture. They can text us, they can schedule appointments. There's a whole bunch of phenomenal educational material that's built into the app as well. And using this closed feedback loop system, we're able to, through synchronous telemedicine visits and asynchronous coaching, we're able to meet with the patient and figure out what's going on. So, for example, if someone has severe hypoxic obstructive sleep apnea AHI is 60, high loop gain features, supine dominant, etc., etc. That with high hypoxic burden, that person's probably going to buy themselves a CPAP machine. But if someone has mild apnea, moderate apnea, upper airway resistance ish type of a picture, then I think there's like a ton of solutions that are available for these people, especially if we can track them across time, ranging from like mouth tape, nasal strips, myofunctional therapy, to ENT procedures, to dental appliances, to Excito-SA, and so forth. And now there's ApneaMed has this drug coming to the market. So there's going to be more and more solutions. And the best way, at least what I believe is an intelligent way to prescribe this, is by endotyping, phenotyping, seeing what's going on, and then accordingly measuring the efficacy of that solution that we prescribe or ask the patient to do. And that mindset is both applicable in insomnia, in restless legs, in sleep apnea, in circadian rhythm disorders, and so forth. So, I mean, diabetes is. I'm really inspired by continuous glucose monitors and like what what CGMs have done for diabetes care. I want us to be able to do that for sleep. And the whole goal is to take someone from lousy, crappy sleep to substantially better sleep in as quickly short period of time as possible. And typically for us, it just depends on what's going on. Severe apnea probably is like a 2 to 3 month journey. Like the COMISA patients are maybe like a 3 to 6 month journey. And this is like with a lot of hand holding, white glove service, coaching, CBTI, all of this stuff. And what you'll see is like when you start tracking sleep longitudinally, subjectively one may start feeling better. Objectively, it's really hard to move the needle, depending on what disorder is going on. Modulating autonomic nervous system activity during sleep is really challenging. Like those folks who have chronic insomnia for decades on sedatives, hypnotics, with low arousal threshold, conditioned arousal, they're going to be like a 6 month to a 1 year journey to really get their sleep dialed in. Like that's not the person who's going to walk into clinic, here's a PDF and I'll see you in 6 months, and they're not going to have any kind of like positive outcome. But when you give them a sensor, provide them good coaching, good services, and you're tracking the data either with their visibility or without. In the app, we can actually turn off the ability for the patient to see what's going on to their sleep to reduce any orthosomnia. But you get the idea. The more data we have, the better, the more intelligent kind of feedback and guidance I can give to the patient to get them to where they want to be. The journey looks something like this. So, traditional single night testing at day 0, sleep studies get used as like this, and it kind of gets underneath my skin, where someone gets a sleep study, clearly has horrible RLS, insomnia, delayed sleep phase. We find out they have an AHI 3% of, 7. Someone prescribes them a CPAP machine, thinking this is all obstructive sleep apnea, when nobody's really getting a good history. So what's really important to us and to me is like getting that good history to really figure out like it's not sleep apnea that's the driver of the problem, it's all these other things. And sure, we might need to treat the obstructive sleep apnea at some point in time, but this is clearly like a COMISA plus RLS plus a delayed sleep phase picture, and like all of these other things are really going to be the levers that are going to help this person with coaching, CBTI, and then we can address the sleep apnea when we need to. And single night testing really doesn't allow us to do that. So in a single night testing model, one night testing, automatic CPAP or some other solution, you might, if you're lucky, you might get a follow-up study. Most people will not. But if you have the ability to test frequently across time, you'll get a good baseline assessment to see night-to-night variability. You can introduce an intervention. You can then, one of the things that we're doing here is we're optimizing their CPAP machines with home titrations. These machines are cloud connected to the platform. They can upload their SD card data to the platform as well to be able to look at waveform analysis. This waveform analysis is overlaid with the waveform analysis of the sleep study. So really just unlocking home titration studies for patients. So we'll be able to optimize pressures. We can modify the masks, and like I'm a big fan of optimizing nasal breathing and then really building good habits to get people to substantially better sleep over a very short period of time. And we've been doing this now, man, for 4 years or so. I would say we've done over um, 1 million hours of sleep testing. We've done over uh, the number somewhere between 100 and 150,000 nights of sleep testing over the last 4 years, and we have a pretty good system now, a handle on this pattern recognition of like who is going to do well with what kind of modality, and I'll share when if it makes sense and we meet, I'll share the AI tools that we're building to help us figure these things out much faster. So who's the ideal candidate? Like it's critical, it's imperative that whoever we bring on is uh, really understands like sleep physiology from a first principles mindset, wants to look beyond apnea, and is very open to the idea of optimizing sleep for NBA player or a football player, is like very familiar with optimizing jet lag strategies, is really taking a physiology driven approach to both like breathing, to circadian rhythms, to sleep, to all of these things. Okay. Um, like the kind of things that you're probably doing in a fellowship program. Like I want us to be able to provide that kind of sleep care here at EmpowerSleep. We get patients from Stanford, from Harvard, from MGH, and like we want to be able to be that parallel referral to be able to take care of complex disorders and look at it through a very physiologic lens. The second thing is like, we're a telemedicine practice. We don't see patients in, we see patients synchronously and asynchronously. Everything is done on Zoom. So if someone doesn't feel comfortable on Zoom, like this is like not going to be a good fit. This person, whoever joins, needs to have a high level of comfort with digital healthcare, using different tools from EHRs, which I mean, most physicians are already used to it, but there's a very distinct difference between working in a clinic and being able to walk down the hallway and asking someone to do something versus sending them a message on Slack or sending them an email and getting something to get done. So it's a fully virtual care environment. We're looking for people who love technology, like people that are, there has to be a decent level of skepticism, but still a high level of openness to explore, to understand what are the different solutions that exist, what are the new technologies coming into the marketplace. I'm like a big guinea pig for trying different things on myself, to see, does it work, does it not work, how does it work, and making my own opinion while looking at the literature and seeing what the literature suggests and who would be a good candidate, like what endotype and phenotypic presentation would be a good solution for what kind of an individual. I don't know if like a 1 year sleep medicine fellowship really prepares someone for this. So I think ideally I would like to have someone who has at least a few years of clinical experience. Um, but I'm open. I'm very open to talking to folks who are fresh out of fellowship, but like maybe they may have some unique experiences that might make them a good fit. And then working autonomously, like no one's going to babysit anybody. Our care team is across uh, the entire United States, so working autonomously, working in your time zone, no one's going to, you know, track who's doing what. Like patients will fall on your calendar. We on a daily basis, what in terms of what the day looks like, um, uh, it's a 9 to 5 PST clinical day, and that time zone will shift for wherever you want it to be. An hour every week is for town hall meeting where we all meet as a team with engineering, with growth, with operations, with care coordination, and the care team to understand what's the goal for the week as an organization. And then on the clinical side, I'll meet with all of our clinical team every day um, for 30 minutes to just sync, understand like what are some issues that we might be running into, what's the plan for the day, discuss any complex patients, and obviously everyone has a an hour lunch. And then what we started doing maybe 2 months ago. I'm a big fan of like continuous ongoing education. So I've subscribed everybody to join the fellow lectures and the faculty lectures at Beth Israel Deaconess Medical Center where I trained. So we attend those lectures. It's an hour lecture every Wednesday, and that is like phenomenal. It keeps us connected. It's like grand rounds, so to speak. It keeps us connected with academic medicine, being able to talk to other fellows. It's a great way for us to recruit and grow the team, as well as stay really connected to people that I believe are more intelligent than I am. So that's kind of the culture here is like work hard, um, be like deeply connected to the science while being open minded, and be very physiology driven and always trying to think outside the box. Um, so what you will do, I kind of talked about this already, but so in terms of like the split, 80% is clinical, 20% is admin, reading sleep studies. We do about right now anywhere between like 40 to 80 sleep studies a week, and I don't know, by the time this things change every month. We've been growing, so by the time you might see this, that number might be different. um, the pathology is your usual sleep medicine pathology. In our program, about, I would say, I think in a traditional sleep medicine program, 90% of patients are sleep apnea patients. I would say in our program, it's about 60 to 70% are sleep apnea. The remaining are a mix of RLS, circadian rhythm, insomnia type of, and then there's going to be that overlap. And then there's about maybe 5 to 10% or like sleep, maybe 5% are sleep optimization type of folks, athletes who really want to improve and optimize their sleep. So that's what that. Those are the kind of clinical scenarios that you'll be um, where you'll be taking care of patients. In terms of other things that you'll be doing is really just like thinking outside the box. And I put here growth, innovation, AI implementation. Um, there's a lot of fun things that we're doing on the AI front, both of like just using off the shelf tools of like these ambient scribes that can listen into the conversation and do the documentation in the background, but also we've built our own AI engine that sits on top of a couple of different LLMs to process data, to view data. And the idea is to build like a chat GPT, like a physician agent for sleep that can eventually be able to tell us like what's the best way to take care of this patient based on the data that we have, what medicines are working, what is trazodone more effective than doxepin versus Ambien versus Adora versus something else. So that's the idea, because I think everyone responds when you start doing longitudinal testing. You'll see everyone responds very differently, both subjectively as well as objectively, in terms of how their sleep architecture changes. So being very innovative centric and AI centric, it's critical. It's imperative that whoever joins a team is of a collaborative mindset. Um, you're going to be working with the care coordination team. You're going to be working with engineering. You're going to be working with operations. Things break all the time in a startup. That's expected. And if it doesn't, like, we're not revving hard enough is the mindset here. So being able to work across multiple teams, be able to have a solution centric mindset. I think most of us have been there, especially those of us who are exploring other things. You go hang out in a physician dictation room and you see most of the people there are kind of complaining and not really solution centric. And I want everyone on our team, the culture is really to be solution centric. Like, instead of, yes, this is a problem, but like, I think these are some solutions, and let's think through what would be the fastest solution to solving that problem in a very resourceful way. So that's the mindset that really would thrive here. and then working across systems and helping optimize processes. If something isn't working, again, not complaining about it, but saying, hey, this is like I think a solution, and all right, let's try it and see what happens. If it works, that's great. If it doesn't, that's okay. Let's find a different solution. What's the offer? Okay, so as I mentioned, everything is fully remote. We do have a employer-sponsored health plan that we launched in 2025. In 2026, we're launching a retirement program. All the entire team has we give I'm a 4 weeks vacation. Compensation is on the higher end for sleep medicine, in the higher, I would say, quartile, even for a in-person private practice job, and the range is between 250 to 300, and I think that's, I guess it just kind of depends on the person's experience. And then on the equity side, I want everyone on the team to have equity, from the care coordinator to the NPs to the coaches to the docs to the engineers. We're building for scale, and I don't believe in this like traditional physician model of join my practice and I'll see if I like you in 2 or 3 years, and maybe I'll make you partner, maybe I won't, maybe you can buy in, maybe you can't. It's just this like nebulous, vague nonsense. Like we have a very structured equity model. It's a 4-year vesting period. Everyone is the same on the physician side, and everyone has equity in the organization. I want everyone to have a phenomenal exit as we continue to grow, and I want everyone to do well. Okay, yes. Let me go back. What does this say? If this is okay, yes. As you can see, like I'm really big on making videos, whether it's for this kind of asynchronous communication. So what I need from you, if you feel like this is a good fit and you feel that, hey, I thrive in this kind of a environment, I feel suffocated in an environment of like maybe the VA or Kaiser, like this really Goliath of a health system where things don't change for years at a time. I need a video from you of like why you're interested. Just keep it simple. Like I'm, just keeping it real. Just make me a video of why you think this is a good fit, why you're interested, and why you think that you would be a great candidate here. 5 minutes. You can go longer. You can go shorter. But just it doesn't need to be formal. Please don't script it. Just if you want to make bullet points, you're welcome to do that. But just keep it very authentic on why you think this is a good fit for you. And if you don't feel comfortable posting a video on YouTube because of your current employer, you can email it to me, or you can email it to care, at EmpowerSleep.com, and they'll forward it to me. But without a video, like none of the applications will be considered. And if after the video, we'll
Dr. Mogadon 6800. Dr. Mogadon 6800.
sorry about the overhead page. After that, what will happen is we'll have about 3 to 4 interviews. You'll meet with Stacy, with Callie, with someone else on the ops side. This is going to be a pretty quick onboarding process. Most physicians have a 90-day resignation notice, and during that time, we'll get you licensed in all of the states that need to be licensed in. And for most of us, I want everyone to be licensed in as many states as possible, so there's cross coverage. And there's going to be a 2 to 4 week learning curve. I think, unless if you're using some of the technologies like sleep image in a longitudinal fashion, or Wesper or Balloon Tech, and like tracking sleep longitudinally. If you haven't done it before, it's going to be pretty eye-opening, and so there's going to be like a few week learning curve, but that's okay. Like we're here to help. We've been doing this for a few years now, and sorry, this video was supposed to be short. I talk a lot. I'm sorry it went over. But I'm looking forward to meeting you all. I hope you have a good lay of the landscape of like, you should be able to know by now if this like a good fit for you or not. And if it is, apply. If it's not, I totally get it. and I wish you all the best. Thank you. Bye bye.